fellow colleagues from different medical specialties, nursing staff, and medical students. In child and adolescent psychiatry, severe behavioral dysregulation is rarely an isolated issue. It's often the final language left to a child, facing multiple overwhelming compounding issues. Today, we will reveal how a series of specific life events systematically led to a behavioral and functional decline of a child. Our patient is MI, a 15-year-old Gujarati Muslim boy currently studying in Form 4 mainstream class. He lives with his family that includes his great aunt. He, too, posts an OKU card registered for a physical disability.
Yeah.
He was given to us with a primary triad of chip complaints, chronic school refusal, intense mood behavioral issues, and severe physical aggression. These clinical behaviors have become increasingly difficult for his family to manage since 2023, beginning when the patient was 3 years old. To look at his baseline, MI was delivered via emergency cesarean section at 8 weeks following a failed induction of labor. His mother pregnancy was complicated by gestational diabetes requiring insulin. But his birth weight was healthy 2.88 kg and his early developmental milestones were completely. However, he was identified early in infancy as having a difficult temperament marked by frequent crying and fussiness when his demand was not immediately met. So let us go through his story in different phases, from initial trauma to the functional breakdown. At the age of 6, MI survived a severe motor vehicle accident, sustaining multiple physical injuries that require a 1-month hospital admission and the surgical amputation of his left, first, second, and third toes. 2 months post-trauma during which severe irritability and disruptive behavior emerged. He screamed and he stuck. He also attempted to physically implant toys and objects into his foot, with over old photos asking to attach his toe, and constantly questioned why his siblings did not suffer the similar fate. Due to his severe distress, he was then referred to a psychiatrist at the age of 7. Following this incident, he experienced persistent peer bullying and verbal abuse due to his physical impairment. His temperament shifted towards worsening aggression, and he displayed an inattentive presentation, leading to a diagnosis of ADHD at the age of 11. Shortly thereafter, he suffered a profound attachment loss due to the sudden death of his maternal grandmother. Driven by the ongoing school refusal, he was transferred to a Tafi school for 3 weeks and later to School A in Form 1. In both environments, he was subjected to a severe physical bullying and sexual harassment, leading to a deep-seated trauma isolation and a perception of family abandonment. His family also noted an intense obsessive control, which the sister describing him as controlling, excessively jealous, like a man madly in love. By the age of 14, his behavior escalated into extreme aggression and obsessive control. After years of unresolved trauma and chronic victimization, he forced his mother to use exclusive pet names like Merah Beta, my lovely son, while flooding her with over 10 phone calls over a day. He also choked his mother and smashed household electronics. He weaponized past family grievance to justify his violence, tore apart his sister's academic textbook, shredded his father's passport, and also aggressively tried to jump out from a moving car. So this high-risk profile led to his first psychiatric ward admission at the age of 14. Today, he remains trapped in a frustrating, repeating rebound cycle. The fragile stability we achieved within the safety of the ward completely collapsed within a mere weeks of returning home, sending him right back into severe behavioral relapse, rigid medication refusal, and complete school refusal. So now we move on to the past medical and surgical history. So physically, his history is defined by an accident at the age of 6, which require multiple surgical operations. He also presents with delayed puberty at tenor stage 2 and a persistent physical deformity which requires specialized orthotic bones, which he frequently refuses to wear. He has a multiple psychiatric admission since the age of 14, lasting from 2 weeks to extended 10-week stay, all driven by unmanageable aggression. So now we look at the genogram, the family genogram. We can see that there's a significant psychiatric and systemic vulnerability. So his mother is unemployed and diagnosed with bipolar 2 disorder, which she has defaulted, resulting in a highly permissive parenting style. On the other hand, his father is a pharmaceutical representative who migrated to Malaysia, exhibits an inconsistent and punitive parenting style. There is a documented history as well of domestic violence where the father physically assaulted the mother. Furthermore, the father and sister have actively recorded videos of MI outbursts which deeply exacerbated his feeling of hostility and alienation. So moving on to clinical and psychometric tests. So objective psychometric evaluation ground is systemic stresses. So on the Wechsler intelligence scales for children, MI achieved a full scale IQ of 57, which indicates a mild intellectual disability. His Vinland 3 adaptive assessment also shows a low communication index and moderately low adaptive behavioral component. So the discrepancy also noted at the ADHD presentation, where his parents reported a low combined score at the Vanderbilt scale, whereas the teacher ratings on the corner scales reveal a highly elevated ADHD index, which shows that the behavioral and cognitive deficits are profoundly exacerbated in a structured, social demanding educational settings. So during our mental state examination in the ward during the admission, MI presented as a cooperative but shy and anxious boy, maintaining only intermittent fleeting eye contact. A mild fine hand tremor was noted bilaterally. He spoke in Malay with a low tone and volume, offering brief and simple answers, and become highly tearful and distressed when discussing this family or discharge. His mode was eutymic and with a congruent effect. No formal thought disorder or perceptual disturbance were noticed. Crucially, he was preoccupied with negotiating alternatives discharge option, explicitly pleading to be sent to an orphanage rather than returning to his family home. So our provisional diagnosis for this case is oppositional defiant disorder and intellectual disability with differentials of attention deficit hyperactive disorder, ADHD, and intermittent explosive disorder. We can see from this case formulation that his presentation is driven by a complex interplay of biological vulnerabilities, acute environmental triggers, and perpetuating household dynamics. From a pharmacological standpoint, managing MI has been a challenge due to a high neuroleptic sensitivity. He previously failed to respond or tolerate ADHD medications, including Ritalin and atomoxetine. More critically, he developed severe extrapyramidal side effects when trial on risperidone, lurazidone, and sustained injection. So, in December 2025, we also carefully re-challenged him with a combination of tabendazole and tabendazole with a monthly injection of flanzol. This specific regime has been successfully tolerated in the ward with no extrapyramidal symptoms were seen. So now, moving on to multidisciplinary management. Because pharmacotherapy alone cannot resolve a systemic breakdown of this skill. Our long-term stability plan relies heavily on multimodal, multidisciplinary intervention strategy divided between work-based behavioral modification and community reinforcement. We have actively initiated continuous psychoeducation and structured family interventions. Early this year, treating team of MI and his parents formally signed a behavioral contract. This contract established strict household boundaries, limits mobile phone use, and mandate the rules of highly structured tools, such as the daily record and daily family time commitment records. Due to the deep clinical complexity of this case, he was also referred to a clinical psychologist for assessment and behavioral for behavioral modification. As for community psychiatry and social work team, he was referred for medication funding and finding suitable placements. So I would like to hand over the floor over to my colleague from community psychiatry. With that, thank you.
Thank you, Dr. Hui. So our next speaker is Staff Nurse Najmuddin. Staff Nurse Najmuddin is from Community Psychiatry and Psychosocial Work.
Assalamualaikum dan selamat pagi. Saya sangat Najmuddin daripada Fakulti. Hari ini saya akan menceritakan tentang pesakit atau klien berdasarkan dari pandang mata badan komuniti lah. So sebelum itu saya akan menceritakan sikit tentang UKI ataupun unit secondary community dan intervensi psychosocial. So apa itu? So unit secondary community merupakan salah satu unit di bawah Jabatan Psikiatri dan telah ditubuhkan pada 2002 bagi menyediakan perkhidmatan sokongan psikiatrik di bahagian komuniti ataupun di luar hospital lah. So, selaras dengan pendekatan rawatan holistik yang menekankan kesinambungan penjagaan sakit di luar fasiliti hospital. Rangkumi daripada rawatan, pencegahan dan juga promosi kesihatan. Okey, dalam ini kita pasukan multidisiplin. So kita ada pakar perubatan, pegawai perubatan, jururawat, pegawai dan juru pulih secara kerja. Kami dalam pasukan multidisiplin. So ada pakar perubatan, pegawai perubatan, jururawat, pegawai dan juru pulih cara kerja, pembantu perawatan kesihatan dan juga pembantu tabib. So ini adalah teras perkhidmatan yang kami lakukan di community service. So ada 3. So first kita akan pada illness control dia lah. Kita akan tengok pada dia punya bahagian ubatan dan sistem sakit. Lepas tu yang kedua kita akan tengok psychosocial support sama ada dari segi financial, emotional dia dan juga social dia lah. Dan yang ketiga adalah rehabilitasi dan recovery. Okey. Ini adalah tempat sakit lah. Sakit tinggal di taman berdekatan dengan Bandar Tun Razak. Duduk di standard house. Ada pegawai jaga di situ. So, ini adalah kawasan depan rumah pesakit. Dan ini adalah rumah pesakit. So, pesakit ni rumah depan dengan taman lah. Okay, saya akan ceritakan 2 situasi sebab saya sebelum ni banyak melihat kes-kes dewasa. So, untuk kes-kes saya ni saya kurang pengalaman.
So, saya habis perubatan. Sebelum dia buat spes ya. Tes ya, saya lupa dengan dia untuk hotel tak ada. Saya ingatkan ini macam jenis lain berarti. Sebab dia nak macam sakit sangat dewasa ni tak kena ini ada yang manipulate sebab tak ada sakit. Sebab saya ni, saya jumpa dia di surau, saya tengok dia okey, tak ada masalah. Boleh cakap dengan kita, basic behavior. Mas, okay, ini ada mas ingat siap deh. So untuk gambar bilik dia saya tak pick. Selama situ ada dengan apps, Apple Fit, dia tenang gambar. Bilik dia memang kemana, tapi dia cakap dia sebelah daripada bilik dia tu bilik kakak dia. So ni tenda bilik kakak. Ya betul. Pakuan barang apa semua dah dan bilik kakak dia. Dan situasi yang kedua adalah apabila saya datang tidak untuk tahu sakit lah. So pesakit tu bila sekolah saya datang beritahu mak dia tak cuma kata sakit lah yang adalah bisik sakit masih mak dia dah ada sakit tak sadar apa semua. Ini adalah parah-parah rumah yang telah pecahkan lah. Ada model kita rumah ataupun piko mana yang didapat pecahan. Rasa dah pecahkan barang. Ini hadapan ini pesakit lah. Yes. Sip. Okay, at some first start, but we didn't back. This is space. So our next we will what help with the patient back. This. 1 is 3. This case. Good morning, everyone. Please to the problem for you to see by slides for 1 minute. Good morning, everyone. My name is Melia. I'm a senior clinical psychologist from Psychology Unit Hospital TARIKH. Following from Dr. Lim Hui Ying's and also Dr. Najmuddin's presentation, so I'll be presenting from the clinical psychology point of view on this case. So the patient was referred as last year, 2025, in January. At that time, she was at most repeated sleep on me, not on the medications at the time of referral, or when I was through the child had started different medication. So he was referred for anger management and behavior modification. The main concerns were mainly the contracts, aggressiveness, irritability, and constant motioning seeking from under. As you can repeating from what Dr. Hui Ying and also the self-assumption, the aggressive behaviors and shown in the pictures. So that was referral concern. And when I first saw the case, the first few sections, I captured the review after. So at home, she was behavior immature, essentially sitting and aggressive. So she would break icons. She came on to his mother. They would ask the same questions, like whether the mother loves sleep. And she will request or demand the mother to sing box. She loves sleep every day. Call him to sleep every day, massage him before sleep, help sleep, and even carries him to sleep. But this has stopped because his child has grown and mother longer condition. He also demanded the family members to repeatedly say the please is my lovely brother. So, as mentioned by Lim Hui Ying, like he will also call her repeatedly. She did not see her. he will request her to be on sleeper if she's on his phone. He will sit on top of the siblings. He will disturb them when they are doing homework. He says bad words, cursing, blaming mother. He threatens to destroy the house. The bridge. But from what mother reported and as well as observed in the clinic before, observed in the clinic, she was cooperative. He was able to engage activities once Rabu was still. He was polite. According to the mother, he was also head of librarian at one time. In the first 2 sessions, it's very hard for him to separate from the mother. So she refused to let mother to talk to me in a strict sessions. But after Rabu meeting, she was able to do that. So as you can see, behavior varies across the environment. So as my behavior observation, he is heavily dressed with small cap. He was pleasant boy, but guarded. He often close to London for comfort or reassurance. But subsequently, when rapport has been built, he was cooperative. His work structure is from anxious, withdrawn, tearful episodes, but later on during the MCs, cooperative was not with me. He was motivated to do my homework. He speaks majority with mother initially when I told him that I could not understand what he said, and suddenly he was speaking English mixed with Malay. His responses are mostly brief and 2 to 3 words. He struggles with complex, open-ended questions. He needed simplified instructions or gestures to understand what I actually needed him to do. Observe some mild tremors at hand due to the sleep of teaching. Otherwise, attention span is thanks to it. No hyperactive observations, but definitely insight and judgments work. When I introduced myself that I'm a clinical psychologist, she protested that I'm not, and therefore she doesn't want to see me. Or she doesn't want a concept of psychology because with the center of psychology, she thinks that it should be support or be superior. So she's a very self-conscious. So with all these questions that I have in mind, and also his diagnosis, so I proceeded with IQ assessment to really understand why she didn't sleep as such. So IQ assessment was done as shared by the Fakulti themselves. So I did Wesley typing still for children the sleep version. Used English and mixed with Malay between because that is his comfort knowledge. So as you can see here, Proof's IQ is 57 within the extremely low range, but there is significant discrepancy between indexes. In this case, then I will use GAI, which is General Ability Index Score, which is also fall within the extremely low range. The significant difference is because the persistence there is within the below average range. This means that he struggles with higher order thinking, logical reasoning, but he was able to feel interest from simple routine. So that's why sometimes it seems that he do understand what people observe. So the cognitive assessments reveal the overall intellectual margin is declared. So next, I also did the adaptive assessments using Wyman 3. So as you can see here, adaptive behavior composite is within moderate low range. But overall, it's considered that she does show deficit in adaptive function. But his personal strength is in daily skills, which also, for insight, consistent with the IQ profile, suggesting that she can't manage routine tasks, but she struggles with affect and social bonds. With this two assessment and the background histories, and then also the observations, I think the child fulfilled the diagnosis criteria for intellectual disability to the DS5, which is shows deficit in intellectual functions confirmed by the IQ score. It also showed deficit in adaptive functioning. The onset is during the development period, and the severity specified is within the boundary. Because of the ADHD and the behavior profile that was recorded, I proceeded to fill the behavior rating skills. As you can see there, the CBCL and YSL reported highlighted the discrepancy between mother and child. So mother rated 2 different levels for internalizing, externalizing, and total problems. The child, otherwise, self-reports are all normal. So reflecting limited insight and possible minimalizations of difficulties. And I wanted to highlight the attention problems as also shared by Dr. Faye, like it's also within the boundaries from the child's perspective, from the potential swap. I wasn't able to gather any information from the school because the child refuses to let school say anything. And mother is afraid that child would retaliate or be sent to her if she did herself. I was eager to also call the school to find out further, but according to the father's schools, teachers have always said that he was applying to support students, and because she was at one point head of library, so I assumed that things were pretty good and well in schools. So my key formulations is that the predisposed intellectual disability, physical disability due to his limitations of his left course, trauma, is also shown by Dr. Ray, like the abuse, the bullying, and also the sexual harassment schools of home, precipitating by the passive abandonment. So he was enrolled to Catholic school to fulfill his late grandmother's wish, but then changed back after 2 weeks because with the boarding students, and then 3 weeks, parents went back to India to care for the father's sister, and therefore the child perceived that they have abandoned him. Definitely lack of skills in many schools and increased demands, especially for primary school to secondary schools. That's why a lot of issues occurred during this time. Perpetrating by delayed diagnosis, lack of understanding by himself and also people around him, pervasive parenting, maternal burnout, family dynamics, and lack of social support. For the protective factors is otherwise obliging being by sessions, I think in luxury and ward as well, but it's partially instead of what she has done, so she's trying to cut it. Therefore, like what Starfield's extension block, she tried to keep this room hidden, and then the rest of the other places. So acknowledgement, he is his protective factors. So when the demand setting higher, she starts to not able to cope and not able to be participating in any activities. That's why he also resulted in school infections. So intervention, CPT is always the gold standard therapy. But in this case, the child's limited cognitive powers was very hard and difficult to identify cause. He was not able to do that. It's also very difficult for him to identify his emotions. Poor emotion reprocessors is one of the precipitating factors of SOA. And therefore, positive behavior support was chosen. So positive behavior support is also short or PBS is a value-based, evidence-driven approach to support people with behaviors challenge. It focuses on understanding why this behavior occurs, and then we'll create a supportive environment that reduces the stress and promote well-being. Well-being is the key, one of the key features of these treatments. So what function does set was what we asked instead of looking at the behavior itself, like it's just for sexual attention. Is it to avoid demands? Is it to treat the something or provides stimulation? So with this therapy framework, so what I did, the first thing is really the assessment. And from all I proceeded with the IQ and different assessments to help me to understand the individual profile. So first, the child has intellectual disability. And then I also use APC chart and this student behavioral consequences chart to really understand the functions of the behavior, to analyze. And then with this profile, and also what I found out, it is important that we use simple language, especially when Malay or English is not the primary language. Simple language, very clear instructions, and short sentences. I use a lot of visual support, a lot of repetitions. They say a keep introducing real thing. It's really the repetitions that would be possible. So with the assessment, then I move on to the manage difference of blue color. How do I manage this? First, the support education that parenting output. So parents to understand what this behavior, so why they need to feel the functions instead of looking at the behavior inside. Now, parents to understand that the child has this social disability instead of just rather than others manipulative. And then we have a central family activities to serve to fulfill his needs, structured routine, behavioral reinforcement. So in PBS, we focus on reinforcement rather than punishment. It's about rewarding his good behaviors. So what was helpful when I was doing that, there was no shooting for several days, though he still occasionally throw objects. Mother reported that things are a little bit better. So the child can walk in the park but for me, that's not debatable. He was able to set alarm and wake up independently, but not required mom to do that. His anger is better managed, limited, but eventually insight into his emotion. And therefore, I went on to the emotion literacy coming psychologist work section. I was trying to involve family, but usually only mom came to their sessions. So the limited improvements is still to the core, and she was unable to identify, how his moods, his emotions stop. High metabolism or inconsistent follow through. At the back of my mind, I was wondering as well, kind of with therapy, we focus on the child, but also at the mother needs support and required professional help. So a take-home message for today's sharing is that this issue is important with multiple involved. Initially, I was just seeing the mother, but with the sisters community, it was better to have an overall understanding of why how it's behaving as such. The question is adolescents should understand in a trauma-informed developmental cognitive terms. The question is always a communication of attachments. It is the diagnosis if behavior was context. Structured routines, family interventions, trauma-informed psychology care are essential in this phase. And lastly, maternal well-being is critical to the workplace. With this, thank you. Teacher, please sleep. So, I'll be productive work. So, let me sleep. I've watched the next year on which is
Here's what you should know about oppositional defiance. I'm Dr. Sarida, a child and adolescent psychiatrist and associate professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. Oppositional defiant disorder, or ODD, is a persistent and regular pattern of moods and behavior experienced by about 3 to 10% of kids and teens. Kids with ODD have a very hard time with anger and irritability, intense patterns of arguing or defiance, and trouble letting go of negative feelings. This pattern of hostility is more intense and frequent than typical toddler tantrums or adolescent moodiness. It happens weekly to daily for at least 6 months and negatively affects a child's family, school, and social life. One common misperception about oppositional defiant disorder is that it means that kids are either bad or sick. First, it's not about being bad. It's more accurate and helpful to think about these kids as being less skillful in managing their impulses, big emotions, and day-to-day stressors. Most kids with ODD also experience other conditions like attention deficit hyperactivity disorder, or ADHD, and anxiety or sadness. Kids with these challenges are more likely to experience stress in their everyday lives, including in their families, schools, and neighborhoods, compared to those without ODD. This saps their ability to manage big negative feelings. Second, ODD is more like a pattern of emotions and behaviors than an illness. Research has shown that children with ODD tend to become stuck in patterns of interaction called coercive cycles. They often respond negatively to requests or a situation. Adults sometimes respond with their own, less helpful emotional reactions, like anger or backing down from requests, especially when feeling tired or overstretched. With time, these child and adult behaviors can reinforce each other. These patterns can then spill over into parts of kids' lives, including friendships or school. Families often feel exhausted by this cycle and sometimes hopeless about change. One big advancement in understanding ODD is learning that we need an ecological approach. This means supporting kids within their families, schools, and communities. In addition to treating co-occurring conditions like ADHD or anxiety, we also want to support families with evidence-based, positive, and mindful parenting programs that interrupt negative cycles and help soothe stressed out kids. These programs like Triple P, The Incredible Years, Family Checkup, and others have the strongest evidence for ODD. It's also important that governments enact policies that promote peaceful, secure, and positive schools and communities for children and families. It takes a village to reduce the burden of suffering from oppositional defiant disorder. If you're experiencing concerns about your child, talk to your family doctor or pediatrician for recommendations or referrals in your area. The Canadian Pediatric Society and the American Academy of Child and Adolescent Psychiatry also have helpful resources on their websites about ODD and challenging childhood behaviors.
Still, I see that influence of fibers that are critical. It's a that are so probably so we can discussing the case of the really like optics that is well shot that states so the child of every topic to shape up this really good to session discussing oppositions like the software topics. Thank you for fun. Bye. So, as I discussed by Dr. Principal just now, we have the definition of ODD. One question was whether I simply have ODD because the only exhibited the behavior in one setting, which is good, but he was a really good student in school in terms of behavior. He was obedient, quiet. So the teachers did not have any problems. But at home, he was really noisy and broke a lot of things, even elevators. So, but according to the definition of 4DD in the SM5, it does not have to be in multiple settings. It only needs to be exhibited during such. Well, it's like individual, it's not a city. And we count that first we interacted that with product, which state solid. If you're not silence, we consider that there is a biological basis to it. Needs to the three signs of cortex, both emotive and thoughts. Need to be mature individuals, looking things, planned and organized. But this patient goes to patient thought stage to treat thoughts. Thinks of something or feel it. Does not think further. Straight away he does. He wants to hurt someone or break furniture. He does not think again. He straight away does. The other part is in terms of amygdala. His emotions are out of control. He's just already easily something she needs to shoot that. So as Dr. Tracy Bennett was saying, if we view it in terms of logging skill, in terms of being an immature brain, it's not picking up the skills fast enough. Concepts is outdated. Okay? And the environment also does not help. With parents does not have enough understanding about the condition, even though we have discussed with them multiple times. The things like terms of it. So whenever there is ODD, we always have to think if there's something underlying. She has physical disabilities or medical problems and so lead to oppositional defiant disorder. And she also has intellectual disability. So we have to think about whether there's any other different disorders going on, like across ODD. In terms of prevalence, if we want to stand for ODD and for conduct disorder, there's another higher ratio between boys compared to girls because boys tend to show more like so he's still having ODD adolescence because of his maturity, his low IQ, but we can see the conduct for the munching him, although he doesn't steal or lie, but he's actually destroyed a lot. Okay?
So what we worry is about in terms of the clinical trajectory. In the early years, just for this patient, he was a difficult baby, and was temperament to being prone to high in contracts. In primary school, even though obedient and quiet student, actually he started doing a lot of work. Books are empty, there's a lot of scribbling, he's failing in his studies. So that will lead to very good stuff. And then in adolescence, he's involved with negative peers, who teaching curse words, bad behavior, sexual behavior, so his copy. So what we worry is that in adults that will end up having dysfunctional traits or narcissistic traits, or before end up in prison or being involved with. So the gold standard management would be behavioral management training, and or BCIT. I think we do the best of our ability, considering we don't have certification for it in our hospital. I think clinical psychologists still coming up really good job in terms of educating and training, doing therapy with that to show on the public. So, but the problem is that the parents have different approaches to the patient. Father is very harsh or sophisticated. The mother is intensely permissive. And then father also helps the declining professionals because it's only the mother is allowed to absorb whatever is doing to come and see the doctor. So, because psychological therapy is not working, we have more student patient as well. So, we're being aggressive, most considering that atypical antipsychotics for him is a result, and they work depression because she's not very compliant. They also frequently ask not to and get in the good touch. So, when she doesn't get the injection, then they will be lost on. He has been tried on ADHD medications, but he cannot tolerate them. And the other medications like stabilizers or SSRIs, we do not consider to be applicable to him. But in terms of education, this patient refuses to let us discuss with the school. He is actually eligible for PPGI because of his intellectual disability, but he refuses to be seen as autistic developmental disorder. He already has an LP card, but only for its disability, and they cannot afford going to a private school where down shoulder aids. And most people for the most patient in the past 2 weeks or so, we have research into social welfare, HCTM, for in young parental coaching, which means that the social welfare officer will take him to see a judge. If the parents request, he can be taken away to go to Asama Asla or Nasa. He's not eligible for Hamilton. Hamilton is for when you are found in the ops. But before that, or whatever the parents are not willing to give him up or not willing to get him to do the juvenile centers. So we are thinking of, we discussed this just that another boarding school with event courses, but she's very reluctant to boarding school because it's too. So we're still thinking about other things like Yamara. He says yes, but it should usually progressive. It costs a lot to have a child with oppositional defiant disorder. In the US, they have documented that it's not only medical costs with the doctors, clinical staff, but it's there's also parental laws in terms of parents have to bring the child for therapy, or have to work for the furniture that is broken, replacing furniture, and also actually there are other costs such as being brought by the police, calling the police for help, or if she involved in second crime, and also if there's social education. But in Malaysia, because a lot of it is government services, so a lot of it is implemented. But those are invisible costs that the government is paying for all these duties. Okay. So we thank a lot to all the MOs who has been involved in this case. Dr. Fakulti, Suen, apparently Dr. Melia was given a lot of effort taking care of this child. Because psychology unit also helps in the patient multiple times to help with the short case is still evolving. So I'm not sure about where this child is to end up. We also thank both admin for allowing us to use object services. I know it's only for adults, or inspired for us that eventually we can set up child and adolescent community services hopefully very much. So that's all from me, and I be welcome. What was that? What sorry, the things still sick. These things. So I need questions. Yeah, exit. Indeed, I feel it started one like this. The finance now sleep. So it's our that students at possibilities from or ship this crowd to some people that but and also how to smell yourself how it wants check to do some ways to prove that and you did for six that we thought we just stick the role of leadership. There's condition this dispatch. It's so when you have ODD doesn't mean there's indication for medication. But you give the medication because of the which is eating with family members, is breaking a lot of things in the house, it's broken, it's thrown the bodies on the stairs. So up to the point that father has had to call the police to get moved to the Kaki hospital. Previously, mother tended to treat him for a long time at home without coming up to it. Okay, so that's how the case escalated so much. So that's why we are giving him antidepressant already. And for the expression of when it's not complying, we have decided to go out to get options for him. Because they've been kind of solid from Mohamad since we tried to minimize it first. He's lost. We don't think he has bipolar also monitors and margins spend for this basically gets into depression. Yes, but ultimately obviously it does not appear to be scanned. So if that side is not protected on this medication, so it's actually quite okay when it's on medication. It's just when it talks for the point of then such talking to the medication that's all. So he For conduct disorder, yes. More them is to be difficult with conduct, but not forward. I'm reluctant to diagnose him as conduct, but she doesn't feel to be doctor. At the loss with listing the glucose with that in gym or that of intimates more of the issues are what's of course fine. Plus it's so thank you to all the participants for this special progressive series. I'm just wondering in terms of the role of these species in this, how much do you see the potential and in what way from stage to the trajectory of the progression start? Thank you for the question, Dr. G. So then it we involve subatomic one for the family come. It's quite difficult to get the fabric to come. Even this comes, there's a difficulty that at the start, where they are going to say much my level. So, and there's a number of understanding this. The parents don't really understand what we tell. Intellectual ability is a bit on the limited side. So we have to keep going through. And you want to say about triangulation, both, I mean, mother and son is what in ways, but they will do the same thing. So the very concept of our mother does concept of because if they understood what was going on, their behavior wise, it's difficult for them to put shadows with it. That's the people from the form of visual graphic, visual cartoon, scheduling for them. Then only they understood that they have to spend at least 15 minutes a day. They talk to the bar. Otherwise, they don't smoke it. And actually, that's a good resource outside the house. There's a park. So we keep telling the boy, if he's angry, go out and go for a run, go for a jog. But he does not want to do it indoors because it's actually, father can also go out for a walk. Read. It's a foreign stick. Then on the street and 5 people. Shouts, what shall we? Students, I don't know. Update from stays, but what shape of the development? What should be? What needs to? How? Think about that. How to start it's this time. While that's a shuffle. So that it's having start on the shops and the shops. So then what's it? What's what studios and not are this place with what's to be packed depends on office with balance of like up this in up. Should that that it didn't start with students. So these two